A very good afternoon to all. First of all, I thank KSOS and Natasha ma'am for giving me this opportunity. So today's discussion is about RAM, a black sheep in AMD spectrum. The first case is of a 69-year-old female who presented with gradual painless defective vision in the left eye. She gives no systemic history. The best corrected visual acuity is in the right eye is 6-9 parts with an immature senile cataract, and fundus showed dry AMD changes. The best corrected visual acuity in the left eye is 636 parts with a pseudophakia, and the fundus examination of the left eye shows normal disc and vessels. And in the macular region, if you see carefully, you can see a shallow PED, intraretinal exudates and hemorrhages. So in the autofluorescence, there is hypoautofluorescence corresponds to the exudates and hemorrhages. And in the multicolor imaging, if you're seeing, there is a retinal arteriole which is coming. There is a retinal arteriole which is coming into the network and a retinal venule which is draining from the network. So this is the OCT of the eye which showed a PED and intraretinal fluid. I'll discuss it more. So you can see the foveal contour of the eye is altered. There is intraretinal fluid, the intraretinal exudates, a PED with disruption of RPE at the apex of the PED with a homogeneous hyperreflective material corresponding to a network. Beneath the PED also you can see hyperreflective material. So we did an FFA ICG for the patient. The FFA ICG in the face shows a hyperfluorescent dot which is seen at the termination of a retinal vessel, and the fluorescence increases over in the late frames. And in the late frames, we can see a draining venule from the hyperfluorescent spot and increase, and there is diffuse leakage. So, in short, the FFA showed a draining arteriole, a hyperfluorescent hotspot, and a draining venule, and ICG showed a hotspot with a sudden dipping of the retinal vessel. So, patient intervened intravitreal anti-VEGF aflibercept. So, this is the pre-injection and post one dose of Eylea. After first dose of anti-VEGF, the intraretinal fluid has decreased, and when the patient came for follow-up, the visual acuity has improved to 624, and we again advise for the second injection. So, post second dose of Eylea or aflibercept, the height of the PED has significantly gone down. The IRF has completely resolved, but there is some network which is still seen in the OCT. So, this is the OCT post Eylea second dose. So, you can see the PED has come down, but there is still some network. The visual acuity improved to 612, and the patient underwent third dose and is awaited for follow-up. So this in summary, so this was the initial OCT. This is post 2 doses of aflibercept. As you can see, that there is significant improvement in vision as well as in OCT findings. Case 2 is of a 76-year-old male who presented with defective vision in right eye. The best corrected visual acuity was 660 in right eye, and left eye is pseudophakic with dry AMD changes. The fundus photo of the right eye showed macular exudation with intraretinal hemorrhages and fluid. The autofluorescence confirms the findings, and OCT first visit shows intraretinal fluid, hyperreflective material which corresponds to the network, subretinal fluid, and a shallow PED. This patient also underwent a FFA ICG. So here also we can see a hyperfluorescent spot or a hotspot at the termination of a retinal vessel, and there is late leakage. The patient underwent intravitreal injection ranibizumab. Post intravitreal anti-VEGF first dose itself, the IRF has gone completely, and there is only hyperreflective material is remaining. However, when we saw the patient clinically, there were still exudation and hemorrhages. So we repeated the dose of anti-VEGF, and post anti-VEGF third dose, the visual acuity improved to 612. The IRF has gone completely, and the exudates also decreased considerably. So this is the summary. When the patient came, his visual acuity was 660, and post 3 doses, his visual acuity has improved to 612, and the patient is really happy. So what is this? From the fundus, we can see superficial intraretinal hemorrhages, exudates, and a PED. Whenever we see these three findings, it is pointing towards RAP or retinal angiomatous proliferation. So, other findings what we can see is retinochoroidal anastomosis or reticular pseudodrusen. So, RAP is a distinct form of ARMD, which is otherwise called as type 3 CNV. What happens in the in normal age-related macular degeneration is that the neovascularization starts from the choroid, it reaches the RPE and then goes into the retina for forming a choroidoretinal anastomosis. But in RAP, the reverse happens. That is, the neovascularization starts in the retina and it moves to the choroid. This is also known as deep retinal vascular anomalous complex or retinochoroidal anastomosis. There are 3 stages. Stage 1 is intraretinal neovascularization, where the IRN arises from the deep capillary plexus, and clinically we can see it as intraretinal hemorrhage or a mount or a nodular mass. In stage 2, what happens is this neovascularization extends to the photoreceptor layer, forming a subretinal neovascular network, and it is associated with neurosensory detachment. Retinoretinal anastomosis with a draining with a arteriole and venule can be seen, and this communication resembles a hairpin lobe. Stage 2 subretinal neovascularization, that is, it may or may not be associated with PED. So when the neovascularization reaches the RPE, the PED is formed, and FFA at this stage can be mistaken for hotspots of occult CNVM. ICG in this stage also show hotspots. Stage 3 is choroidal neovascularization. That is the final stage of a stage with retinochoroidal anastomosis, and ICG showed the presence of choroidal neovascularization. FFA is useful only in the diagnosis of early RAP lesions. Late stages can be confused with occult CNVM. ICG shows hotspot in mid and late frames. Hairpin loops can also be appreciated, and it can also reveal the retinochoroidal anastomosis clearly. What is the difference between the typical CNVM and RAP? The patients in RAP seems to be much older, and mostly it is intraretinal hemorrhages. The subretinal bleeds are relatively rare in RAP, and usually it is seen at the parafoveal area and not at the fovea. So management options, it includes anti-VEGFs, ablative methods, and combination treatment. Going to one of the major trials, which is CAT trial. CAT trial in RAP says that the incidence of RAP was around 10.7% in the normal population, and it says that at 1 and 2 years after anti-VEGFs, the outcome is really good, and RAP responds much faster to the anti-VEGF than other forms of AMDs. Differential diagnosis includes IGT, PCV, CNVM, and macular BRVO. So take-home message from this talk is that in all cases of PED with exudation after PCV, after 50 years, we should rule out RAP and PCV. And whenever there is intraretinal blood, exudates, and a PED, the diagnosis is more in favor of a RAP lesion. So I would like to ask a few questions to the panelists. First is, what is the role of ablative methods, including the latest micropulse laser, madam?
So I think we'll go to the diagnosis first, because that will be more important for the audience. Let's go to that OCT picture. The previous case, first case. Yes. So the one thing we can remember from this picture, whenever we do an OCT in a CNVM, the underlying RP is always disrupted. So here you can see that the Bruch's membrane is nicely seen. It is more like a straight line. There is no disruption there at all, because the CNVM has not grown from below. It is growing from above, and it is becoming a CNVM. It has not become a CNVM yet. So the presence of intraretinal hemorrhage without subretinal hemorrhages. So subretinal means that there is definitely subretinal CNVM. So here presence of intraretinal without subretinal component at all. You can get intraretinal in CNVM. That's why I'm specifying that, because in a CNVM you can get both intraretinal and subretinal. But if you just get intraretinal without subretinal in what appears like a CNVM, then you have to suspect that it is a RAP. And the one investigation that helps us a lot, FA helps in the early stage, ICG helps, OCTA. OCT angiography can very nicely pick up this RAP lesion, that vessel that is actually growing into the retinal layers. That is, can be very nicely picked up on OCTA. Treatment, I am like, the study seems to show that it responds nicely to anti-VEGF. All the RAPs that I have, I'm literally eating my head because it goes down nicely, but it comes up immediately. That is my experience with RAP. So if you stop the anti-VEGF, it will come back. So you have to tell them that they're in for a long haul with this treatment, that they will require as and when needed multiple anti-VEGF injections. It will respond nicely in the beginning, but it will not dry up as much as, or die off as much like a choroidal neovascular membrane. About micropulse, I don't have micropulse. Is there anybody in the audience who has used micropulse for RAP lesions? I don't think so. So we'll leave that question out. Yes, anti-VEGF is the way to go. Anti-VEGF treatment, any of the anti-VEGFs you can use. The higher the anti-VEGF has better results, but everything needs to be repeated. RAP cannot be treated with reloading doses. It will come back. Any doubts from the audience? Thank you, Dr. Neethu, for your presentation.